and welcome to yet another edition of the Health Wrap by the Hindu. This, in video format, is everything you can learn about health on the Hindu in its various formats. Through the Health Wrap, we bring you news, analysis, views and explainers from different parts of the world and point out to you health news you can go back to and read on our website. Do not forget to wait for our expert segment. Today our guest is Dr. V. Mohan, Senior Diabetologist and Chairman of Dr. Mohan's Diabetes Specialties Center, Chennai. He clears the air over the use of these so-called wonder weight loss drugs in the market. So Zubeda, let's talk about the big events that made health news this week.
One of the biggest events this week was a surge in bacterial infections across the world. Europe, for instance, saw a diphtheria outbreak, the largest that they have seen in 70 years. Yeah. Tell us about that, Ramya.
Yeah, so before we go on, I think, bacteria as a unicellular organism that has existed since time immemorial among the first few forms of life on earth. I think when we say bacteria, people think of it as bad bacteria, but there's good bacteria, bad bacteria and neutral bacteria. Know pretty little about the good bacteria. We're learning more, and in the last decade or so, humanity has made great advances in understanding bacteria, the role of bacteria, and in the last few years about good gut bacteria, the microbiota as well. So coming down to Europe, it's interesting to note this because Europe did not have a huge number. It didn't have any significant cases of diphtheria before this, and experts have traced it along the migration route that comes into Europe. So they're saying now that migrants who come into Europe are bringing disease with it. The best thing, of course, is that this is a vaccine preventable disease. So instead of making this a migrant versus resident issue, I think it should be taken up as a public health issue and enough efforts taken to vaccinate people who come into Europe as well.
Absolutely. And at the same time as Europe was battling diphtheria, the United States was battling salmonella.
Yeah. So that's another salmonella infection. It causes disease, and this was traced back to contaminated eggs, and the CDC set out an advisory asking people not to buy a certain batch of eggs. But the fact is that today in the West, so-called developed world, there are increasing cases of infectious diseases. And unless we treat this with the importance that it deserves, we are going and not ignoring it as some random event. Each outbreak has to be taken seriously, particularly in a nation that's not used to outbreaks. So I think, the call is now for the world to sit up and look at public health from infectious diseases point of view very, very seriously.
And focus on One Health as well, right?
Absolutely.
Protecting animal health will help protect human health too. Another study that we reported on this week was that nanoplastics can worsen E. coli infections. It showed that when nanoplastics interact with E. coli bacteria, they actually make them more toxic. Tell us about that, Ramya.
The thing is that why is this significant? Why are we bringing this up? Is because of the pervasive nature of plastics. Studies have shown that micro or nanoplastics have been found even in the bloodstream, the human bloodstream, and even in the brain. So when we look at this kind of pervasiveness, then we have to look at the impact that this might have on human health as well. And as this study shows, it apparently exacerbates the illness caused by E. coli. And clearly we need more and more research on this and money dedicated towards this kind of research for sure.
And that's why June 5th, which was World Environment Day, was a call to actually stop plastic pollution. But moving on to good bacteria, something you mentioned a little while ago, there was a study that found good bacteria in the hot springs in Bihar.
Yeah, and that's interesting because there are studies outside of the country which have sort of looked at bacteria that survive in hot springs outside of India, and some research already exists on that. But this one is from Rajgir in India, and they have looked at bacteria that are heat resistant and seem to have some antimicrobial properties. So I think definitely is a reason to be excited, and let's see what the future brings us in this aspect.
Much needed antimicrobial fighting bacteria. This, all of that we've discussed just now, just goes to show us how crucially and vitally the environment and our bodies are linked. We have been talking so much about climate change of late, and we've had a number of stories this week about that as well. Talk to us about what we reported on this week, the links between climate change and cancer and climate change and leprosy.
So it's very important today. Every week we see the number of articles that come in, stories that come in on the link between climate change and health. They're just increasing by the week. So there is clearly a link, and the changes that are happening because of extreme climate events like extreme heat now. For instance, Delhi and the northern part of India is running very, very high temperatures, 46 and above, and that makes it a heat stress, that causes heat stress. So I think we need to study this. There's also studies that show that pollution, again a climate related event, is linked closely to lung cancer, affects the treatment for lung cancer, and the possibility that the person recovers also is much reduced because of pollution. And we have a story this week, very interesting, on how climate events affect people with leprosy. Given that there is a huge stigma surrounding people who live with leprosy, that endangers their ability to reach healthcare facilities or even seek treatment. And extreme climate events like floods or heavy rain spells and downpours, or even heat stress related situation will further endanger their ability to come and seek health and care.
Just goes to show how climate change and its impacts have to be part of public health policies now.
No doubt.
And while speaking about that, we had an interesting op-ed on exposomix, didn't we? A field that studies how lifelong environmental exposures can affect human health.
Yeah, that's true. I think it is. It's very clear. It was an eye-opening article, actually, something I really loved reading about how the work on the Human Genome Project, mapping of the human genome, has allowed people to study the vast impact of exposures on human health. And for sure, I think this is something that is of interest in the future, and governments should take up exposomics as a serious subject for study, and also integrate it with public health and see what interventions can sort of help us overcome some of these effects of climate change.
Absolutely. Moving on to the other major subject that we had this week, which was brain health. We had a lot of stories with regard to this. One of the things that we covered was dementia, Alzheimer's, and what we know about it.
Yeah, we did that. In fact, record number of stories on brain health and the mind and all that this week, and it's all available in our newsletter and on the website. So there's a lot of information we have today. We've explained what Alzheimer's is, how it's differentiated with dementia, if all Alzheimer's is dementia, if all dementia is Alzheimer's. This is something that we've spoken about, and we've covered a couple of stories on brain tumors. What is the future? What is the future for treatment? How better are we getting at diagnosis? So be sure to read up on our website. And there's also a couple of articles on mental health that were very significant this week.
Yes, because as we continue to read in the news where you say that you have to work this many hours or that many hours per week, but it really does take a toll on mental health, and that is something that is still not spoken about as much as it should be in our country. So we had a story about what this really does to your brain, if you overwork, and the hustle culture.
Yeah, absolutely. So there's a very interesting article. It's also timely, given that a number of celebrities are talking about working non-stop and the work ethic, etc. But even as we look at these recent sort of declarations by celebrities, we should look at how burnout is affecting the younger working population, and there's digital fatigue, which is also coming in the way of work. The answer is not a simple take a screen break or take a walk in the middle of your workday or even yoga. I think it should be a policy level change, and ensure that a culture of good workplace is put in place. And there's also a role for the government in this, as well as private employers, with approaching employees with a sense of empathy.
And taking their mental well-being into consideration.
Absolutely.
Speaking of mental well-being, one of the things that correlates to that is what we eat, what we put into our bodies on a daily basis. And we also had a lot of stories on the importance of diet and nutrients, both macro and micro, this week.
So, this is another sort of, in my opinion, a very healthy trend, because we are speaking so much more about the nutrients and what we put on our plate than we've ever done in the history of humankind. So, even young kids today are talking about how much protein is this and do I cut carbs in my diet. So that's how pervasive it is. So while macronutrients, which proteins, fats and carbs are important for our energy and the work we do to drive us, micronutrients are also very important. These are like small things like potassium, iron, zinc and vitamins, which are required for internal functions. But in excess they might cause a problem. So it's very, very interesting to see what micronutrients do for us, and make sure that we get our dose of micronutrients but not overdose ourselves.
It's all about balance, isn't it? Making sure that
Always.
you always have that optimal, correct balance, whatever it is you're doing.
Also, small dietary shifts, it has been proven, can improve our long-term health. And speaking of advances in general, there's a quick mention here of robotic surgeries that have really come to revolutionize healthcare. They've reduced time spent in the hospital, they've reduced recovery time, and they've also helped people bounce back to normal very, very quickly. And these are becoming common in fields like urology, gynecology and oncology. So less invasive, therefore better recovery and lower cost, because you spend less time in the hospital or at a rehab center.
And therefore you're less out of work, and so the
Yeah,
costs obviously go down.
everything.
Yes. Let's do a quick wrap of the weather. You just mentioned the heat wave that is affecting large parts of North India, but in the south there's just been rains and rains.
Remember last week we had Dr. Monisha come and talk to us about skin health. In this particular season where there's heat and there's the summer rain as well. So weather patterns are sort of unpredictable. We have torrential rainfall in times that we usually never used to have it. And it's become vital to stay hydrated, avoid the peak sun hours, avoid trying to go out during peak sun hours, and protect vulnerable populations. For instance, the Chennai Corporation has apparently set up small pods where gig workers, like people who do delivery and food delivery apps, they can apparently rest when they are out in the hot day sun. It's a small little pod with air conditioning, a place to charge their phones, and all these, I think, give us a sense of hope, because these are all small ways of addressing the larger question of climate change, which we've spoken about elaborately.
Really laudable initiative, and something that perhaps could be replicated elsewhere as well.
So what we're trying to look at today, in the light of emerging evidence that is coming on GLP-1, using GLP-1 for people who are obese and diabetic, there's a lot of evidence that is coming in recently, which says many sorts of things. That one, it is effective; two, it is not as effective as it is in the study population. And among anecdotally also, you have been talking about how it works for some patients, doesn't for others. So if we could just start with the basic criteria you use to determine if a patient is a candidate for GLP-1.
So the what is novel about these compounds and what has made them kind of world famous and become blockbuster drugs is the effect on weight loss. because everything else, see, we have got very powerful anti-diabetic drugs for years to reduce HbA1c. In fact, you can't beat the sulfonylureas and metformin even today. But as far as weight loss is concerned, they've had a very checkered history. And earlier, up to I would say almost 2000, there were virtually no drugs. A drug will come for obesity and it will be withdrawn in 3-4 years' time. Some side effect will come and it will be withdrawn, banned actually. Then once a GLP class of drugs came, they started showing a little bit more weight loss than the other group of drugs, and to an extent which did not come with sibutramine or orlistat or all those kind of earlier drugs. So things were getting exciting. Then came along two molecules. The first one to come was semaglutide, which had profound weight loss, up to about 10 to 15% weight loss, which had never been shown before with any drug. And then, of course, people are scared, oh, it's going to be go off. But now it has stood the test of time. It's been several years, and the drug has stayed. Then people started saying that only stimulates once, only agonist of one incretin hormone in the intestine, that is GLP. There are other hormones. There is GIP. There is glucagon. Why don't we try all that? So the next drug to come out was tirzepatide, which is a dual one, GLP and GIP. That proved to be even bigger than semaglutide in terms of weight loss. So now we started talking about 15 to 20% weight loss. This has been only achieved with bariatric surgery earlier. Now they are working on triple drugs like retatrutide, where GLP, GIP, and glucagon, where they're talking about 25-30% weight loss and all, which is almost equal to bariatric surgery. Those drugs haven't come yet, but the first two are already around. Now the question is, the first question everybody will ask is, because they've had very bad history, are they safe? Well, to be fair, years have now passed and no major side effects like that have come, because they produce little nausea and diarrhea and all that, because they work on the stomach. Barring that, and barring some stray reports, they seem to be generally safe. Now, the question that you asked is, okay, one of the questions people ask me, how long I should take it, which is actually a very difficult question to answer, because any drug works only as long as it's taken. I would imagine it's a miracle if you took a drug for 3 months, the rest of your life, your weight is down. It doesn't happen that way. For that matter, even with diet and exercise, people have lost weight. It's not that they haven't lost weight. People have lost 15-20 kilos even with weight loss, but they regain it. So the same thing happens if you stop the drug. Now with these drugs, luckily, while they are on it, the weight doesn't come back. It plateaus though. It will drop, then one plateau will come and then it will plateau. As long as you take the drug, it maintains like that. Maybe there's a slight drop thereafter. We have not yet seen that while you're on the drug, you still regain. As opposed to bariatric surgery, for example, where you can lose about 30 kilos, but in about 4-5 years' time, you're again regain 10 kilos and so on. So in the trials which have been done where they stopped this drug, one trial was done, SURMOUNT-4, where they actually, one group they stopped the drug, one group they continued the drug. Where they continued the drug, another 3-4 kilos dropped. Whereas when they stopped the drug, the group which stopped the drug in the trial, they gained 50% of the weight within 1 year's time. So these are all randomized clinical trials. In a randomized clinical trial, you are able to have full control. You're always talking to the patient. Every day somebody is calling them. So it's a little art, and they also select patients who are likely to respond. So in an RCT, while it's very good and beautifully done, it can be a little biased because it doesn't reflect the general population. So in the real world evidence happens when you start using the drug. It's come to the market, now you're using it. And a recent paper from Cleveland, I think, which showed that in those who continued the drug, they were able to maintain some weight. In those who were intermittent, didn't take it, stopped taking it, and irregular, they were regaining the weight, which is to be expected actually. So we should not have false hopes about that once you take it for a short time, it will work forever. You also mentioned about non-responsive patients. Well, in the earlier drugs, I used to see liraglutide, before the previous version, we used to see patients, one group in whom the HbA1c will come down and the weight will come down. Second group, HbA1c will come down but weight won't come down. Third group, weight will come down but HbA1c won't come down. And one small group, 20%, both don't come down. So both don't come down, within 2 months, the patient will stop it. Paying for a costly thing for a drug, and then it doesn't even work, they will stop it. But with these drugs, very rarely have I not seen weight loss occurring. It's almost everybody. It's only the intensity of the weight loss. Everybody may not lose 20 kilos. First of all, everybody may not have 20 kilos to lose. See, some may have only 5 kilos to lose. So if they lose 20 kilos, they'll disappear. So it cannot happen. So nature takes care of it. Suppose you're 150 kilos, you're likely to lose 25, 30 kilos. If you are 75 kilos, you're likely to lose 5 to 10 kilos. So that is how nature takes. And when the brain is constantly trying to increase your weight, no, the moment you lose weight, it's trying, its metabolism, it will change. The body is trying to fight back. With all that, the trials have gone well. The experience has been good. In India now, for about 2-3 months, we have had one drug, and the other one is just being introduced. They are fantastic drugs, but they must be reserved for people with obesity. I can't think of a lean person who will benefit very much from this drug. We've got insulin, which is a safe drug, been there for years together. The side effect of insulin is put on weight, but in a lean person, we want them to put on weight. We don't want them to lose further weight. So this is ruled out for people who are very thin, unless they're already on insulin. It can be combined with insulin, of course. So we'll have to select our patient properly. And if weight loss is one of the urgent things, and many people in India are becoming extremely obese. So for such people, I think this makes a big difference.
So, what would be, like you yourself mentioned, doctor, that the costs are pretty high in in the Indian subcontinent, where we are all very price conscious. What would be, you think, some of the common barriers to starting or continuing treatment with these kinds of drugs?
Of course, cost is a factor, because we always compare with the US, and you take one of the drugs which we introduced now, the Lilly drug. Now in the US, it costs more than 1 lakh of rupees if you convert it, 1 to 1.5 lakhs. In India, you're getting it for 20,000 rupees. So we can say it's 5 times, 6 times, 7 times cheaper than in US. That's very good, no doubt about it. But for India, 20,000 rupees is a lot of money. That's one man's salary. For India's average salary may be even lower than that. So when you have people, to that class of people, we cannot even think of giving this. Number one. Number two, the nausea and the vomiting and the diarrhea which occurs is not infrequent. It occurs in virtually 40-50% or more of people. Some people are able to tolerate it well. It subsides after some time. Some just don't like it, and they say, this is making me sick, I don't want to. So that is yet another barrier. Third is that they are injectables. So the moment you talk about injectable, people hate insulin because it's an injectable. Now we're saying weekly once take this, at least weekly once is a good thing. But even then, I didn't realize that you have to inject yourself and all that. I thought it's a tablet. Of course, tablet forms are available. Semaglutide, ribelsis is available in tablet form, but effect you cannot compare. And the side effects are still there, even if you take it orally. So side effects is one, then cost is second. And in the real world study, which was published from the Cleveland Clinic also, dropout rates. So they take it for some time and they say, I'm not losing any more weight. See, people think you'll keep on losing weight. That doesn't happen. After time, plateau will come. So when the plateau comes, they say, why am I taking this drug? I'm not losing any more weight. So they stop it. And then they'll regain the weight. And they'll see, if they stop it, it regains the weight. That's what we told you in the beginning itself. So expectation, and then there is always a lurking fear of some, it's a powerful drug, I'm paying so much for it, making me lose weight, will I, develop some serious side effects? Of course, things like pancreatitis, thyroid, medullary carcinoma, these have been mentioned, but not really common enough to frighten us from using it. Some you use in 1 million cases, 100,000 cases, something. You might find one case like that, which happens with any drug. So beyond that, there's no FDA warning, there is no other black box warning, nothing else has come so far. We don't know another 5 years what's going to happen. Some of the side effects take long time, but as of now, it is safe, and therefore we can continue to use it. Then the other thing which people say is, when you say that, see, you've got a guy with morbid obesity comes, and then we tell them, see, you better take this drug. Instead of going for a surgery, you can use this. No, with diet and exercise, they'll bring it down. See, they don't realize that people have been doing this for the last 50 years, and nobody has really succeeded in keeping their weight off. So that is another thing, another factor which kind of puts people off a little bit. But otherwise, I think the takeoff has been quite good, and a lot of people reading about it and coming and asking me, "Can you give me this drug?" That has also started, because already they heard about it from the US, and now that it's come to India, I welcome the use of such drug. They have to be given under a doctor's prescription. We last thing we want is they going to the pharmacy and then tell give me that weight loss drug, and then they take it without knowing what this patient has got. There are contraindications. If there's a history of pancreatitis, if the history of one more thing which slightly to worry about is that when you lose weight, you lose both fat and muscle. So for people who don't have muscle already, losing muscle can be a problem. So, but that can be overcome. Take protein supplements, do resistance training, build your muscle so that less of muscle. What the companies are saying that it's a 3:1 ratio. So if you lose, let's say 4 kilos in weight, 3 kilos will be fat, 1 kilo will be muscle. You cannot lose only fat. There is no drug which has come that makes you only lose fat without muscle. So you are at the risk of losing some muscle. So in little older people, you lose muscle, you can have falls and all that. So those things you must be careful to give a proper diet to these people so that they get enough protein. Other than that, I think not much problems.
Right. So the impression in the market, as it were, or among people, is that this is, a wonder drug, and once I start this, I can do anything that I want to, eat anything that I want to, biryani, sweets, mangoes, etc. So, what is your advice to you, to someone who might come to you today, who has all the indications to be started on a GLP-1 or a GLI, class of drugs? What would you tell them as a patient who comes?
So when we draw the management of diabetes, we draw it like a building, and we show 4 pillars, and we say the first pillar is diet. Okay, that doesn't change. Whichever new drug comes, that pillar is very important. Which people don't like it, but that's what it is. Second pillar is physical activity, with which you can also include sleep, this, that, all yoga, whatever, meditation, pranayama, all the physical activity related to is second one. Third one is education, because if you don't educate people what to do, like this, false expectations, they must know what to expect, what not to expect, what side effects to expect. They must know what they're spending a lot of money. So obviously they need to be told everything. So the third pillar is education. We cannot just say follow diet, exercise, and don't leave out the third one. The fourth pillar is medication. So this being the fourth pillar, just because now a new wonder drug has come, it doesn't become the first pillar, and the others are pushed off. Because the diet and physical activity will remain even if they stop this drug, whether they take the drug, and if they follow some calorie restriction, the effect is going to be much more, and that is anyway going to help other systems in your body. Your liver fat to go, heart healthy, then keeping your brain function okay, digestion will be good, weight maintenance, sugar control, cholesterol control. So many things come through diet and exercise. So even if you don't have diabetes, I think diet and exercise everybody should follow. So in the case of this, I don't think people should think it's this or that. Oh, I can now get rid of all my diet thing and then only follow this particular drug, which is a wonder drug. It is a wonder drug in one sense because we have never had weight loss to this extent. So to that extent, it's a wonder drug. It's still a drug though. It may be a wonder drug, but it's still a drug. And therefore, we cannot forget the importance of lifestyle modification.
Right. And just maybe one last follow up for the kind of follow ups that you do for patients who are put on drugs. Is it very important to the scheme of things that they have regular follow ups?
Absolutely, because in fact, on a weekly basis, we call them, because this nausea thing can be quite severe for some people. So on a weekly first of all, we start with a small dose. Okay, half the dose only we start. So after giving 4 weeks, it's a weekly injection. So after 4 injections, we actually ask them to come back and ask them, how are you feeling now? Are you okay? And then many people say, I didn't get any side effect. Okay, then you go on to the next dose and let's see The next dose normally is enough. You don't have to keep on going up. In some people, you need to do. So we step up the dose only after meeting the patient after 4 weeks and completely checking with them. What there might not have been weight loss, could have been very minimal, but still, are they okay? At least are they tolerating the drug? That's very important. Second is that after we step up the dose, also we want to know what all benefits we have got. Is it only weight? Is it sugar? Is it cholesterol and triglyceride coming down? Has the BP come down? Can we reduce some of the medications? Chances are that, if they are on insulin, some of them will go off insulin, because once this drug takes effect and the weight comes down, they may not need insulin at all. I'm not talking about type 1 patients, I'm talking about type 2 patients who are on insulin. The weight is going up. Now, if you may be able to stop their daily injections of insulin and replace it with a weekly injection of this. So, and then liver fat, we have to see whether, and then we have to also check whether there are any side effects. So, we'll keep monitoring all the blood parameters and other parameters to make sure that everything is okay. For example, sometimes we might have to measure the amylase and lipase to make sure that there's no pancreatitis and nothing else is there. So again, this is not something which I just tell the patient, okay, 4 weeks you take this, after that you increase the dose, see me after 1 year. It's not like that at all. We have to, because these are new drugs, and for the first time in India we're using them, and under the care of a diabetologist, endocrinologist only it can be prescribed now according to the law. And therefore we have to monitor these patients, and if we see any sign of any danger or anything which you don't expect, but if we see, we have to report it immediately, pharmacovigilance, and ask the patient to stop it also. So sometimes what happens is, a couple of my patients had the side effect was quite bad, not even going with the anti-emetic drugs that we give and all that. So I tell them, you take a break, leave 1 week, let's see how it is. Then they say, now I'm perfectly fine, and say, try one now after missing for it. This time I'm able to take it. So that pause may be needed for some people. So it is individualized for every case. It is individualized, which is why follow-up becomes even more important. And now with the continuous glucose monitoring, we can see how it is coming, and if they have a weighing machine in their house, they can monitor the weight in their house itself.
Should we sign off then with a fun fact?
Yeah, this time I promise you a fun fact that's also weird.
Okay.
So, did you know that even though the neck of a giraffe can be 8 feet long and weigh up to 600 pounds, okay?
Wow.
Do you know how many vertebrae they actually have?
I don't know, I would guess in the dozens.
They have only 7 neck vertebrae, which is the exact number of vertebrae that us humans have.
Oh, wow.
Yep, and that's a wrap. Do remember to watch the Health Wrap by the Hindu, and every second and fourth Friday we have a new version up for you. Thank you.